Hi, I'm Harlan Krumholz, incoming editor of JACC, and I'm here with Rasha and Florentina to talk about an amazing article they've just published in JACC, just presented at EuroPCR in Paris. And guys, tell us a little bit about what's going on.
Thanks very much, Harlan, for having us here today. So what we've got for you today is the first of the secondary analyses from ORBITA II. People might remember the original results of ORBITA II, which showed that PCI for the first time improved symptoms significantly more than a placebo procedure in patients with stable angina and single and multi-vessel disease. And I'll probably hand over to Florentina, who can tell you what happened in terms of her trial.
Yes, so what we did find in ORBITA II that PCI led to greater symptom relief, but we also found that the majority of patients remain symptomatic despite successful procedure with resolution of ischemia. So within our symptom stratified analysis, we wanted to assess which patients stand to gain the most benefit from PCI and for whom the effect will be less effective. So we assessed two main questions. Firstly, whether there was a relationship between symptoms and disease severity. So whether more severe disease is associated with more symptoms. And secondly, whether symptoms could predict the placebo-controlled efficacy of PCI. So we can assess which patients will benefit most from PCI. And in fact, surprisingly, we found little relationship between symptoms and disease severity. So more symptoms do not necessarily indicate worse disease. However, we did find that symptom nature was a powerful predictor of the placebo-controlled efficacy of PCI. We found that patients with rose angina and typical angina were far more likely to be free from angina with PCI than with placebo, and also compared to patients with rose non-angina or more atypical presentations.
Now, it's a fascinating study, and questioning some of the things that we've thought about. Rasha, why is it that tighter stenoses aren't the real cause of worse symptoms? I mean, it would seem on the face that they should be.
Yeah, that is the question that we asked. So we've always been taught to believe, especially me as an interventional cardiologist, that the more disease I see in the cath lab, the more likely they are to have ischemia on a non-invasive or an invasive test, and the more likely that their symptoms will be worse. But in fact, it's probably not true. Those patients that develop stenoses over time probably have a mechanism of lots of different things that happen, including collateralization, including perhaps ischemic preconditioning, all sorts of things that mean that their pain changes over time. Perhaps they modify what they do. There's a number of things that mean that there doesn't seem to be a very tight relationship between the disease severity and the symptoms themselves. So we can't use the angiogram to decide which patients will benefit the most from our PCI.
But so you're seeing that more symptoms get more benefit, even though the stenosis may not be so tight. Can you see a day where we really should be modifying our appropriateness criteria? That actually, as we sit down with patients and talking about the risks and benefits and the strategies, that we're really providing them some quantitative estimate of how much they're going to gain based on how much pain they're suffering.
Yeah, so I think that's exactly what we need to do. We actually need to decide on whether or not PCI might be appropriate in clinic when we ask a patient about their symptoms at the very beginning of their clinical course, long before we do all the various tests that make us start to decide on treatment strategies. It's the symptoms that we aim to improve with angioplasty these days in a post-courage and post-ischemia era. And if we want to improve symptoms, we need to make sure that they have the right kind of symptoms, the symptoms that are likely to be caused by the stenosis, so that we can target PCI to those patients who are most likely to benefit.
Great. Final question for Florentina. So in practice, should we be routinely using these instruments in our assessments of patients? Should we be documenting it in the chart and then using it as we try to help people make the right decisions?
I think we should. I think our results really emphasize that we can assess the likelihood of symptom improvement at the very beginning of the clinical course just by acquiring a good history and taking all of these aspects into account to assess whether these patients will benefit from PCI. So yes, I think these should be incorporated into daily history taking.
No, that's terrific. Hey, we're so glad to publish this in JACC. Glad to see you presenting this in Paris at EuroPCI. And I believe that this paper is going to have a major impact on the field, and really appreciate you coming on today. Thank you.
Thank you very much.